This section of the course is called Perineal Tears. I'm Leslie Cornwell, Certified Nurse Midwife with Empowering Midwifery Education. This is a legal disclaimer we have at the beginning of all of our videos. This information is for general and information purposes only. The content is intended to not substitute for professional, legal, or clinical advice. We strive to keep our information as timely and accurate as possible, but things change, local unique situations. Please omit any errors or admissions. Course objectives: the students will be able to define what exactly is a perineal tear during childbirth, what are the possible causes, what are the different degrees of perineal tears, what are the preventative measures for perineal tears, and how to take care of a woman after a perineal tear occurs. So let's go back to the basics. What exactly is a perineal tear? The perineum is that soft tissue between the vagina and the rectum, and it tends to be the weakest point where trauma happens during the childbirth process. The tearing can be very minimal, we always joke skid marks from the baby coming out, superficial tears, or deeper where it's third, fourth degrees, that it goes partially and completely through the rectum sphincter. So 90% of people birthing for the first time develop some sort of tear, but it's typically not serious and it heals on its own with a few, if any, stitches needed. Especially after women have had babies, it's pretty rare in the out-of-hospital community for stitches to be warranted, but it's important to have the knowledge and skills of how we can prevent them in the first place versus just taking care of the tear. There's different things that cause the tears. It could be manual manipulation by the provider, it could be a fast delivery, it could be the tone of her pelvic muscles, could be scar tissue from a past episiotomy, it could be the baby's position. If there's extra tension on one part of the vaginal opening than another, that puts pressure. So if there's a hand coming out, you tend to have some nasty tears from that with the birth. If the baby's posterior, if the baby's face presentation, if there is a need for an episiotomy, you tend to tear a little bit past that. Ethnicity: there's some studies showing that Asian ethnicity has more risk factors, bigger babies, bigger head, but I've seen it both directions where you have 6-pound babies, but there's so much tension and tightness by the woman's perineum, not good blood flow, some really nasty tears, and then women that have 10-11-pound babies where there's no tears whatsoever. So these are just a few risk factors, but just keeping in context what position they're birthing in, if they're on their back and putting the most pressure on the perineum, if they're in the water and they're squatting where there's equal amount of pressure. Those are all things to consider. The more we manipulate tissue, it spasms and tightens versus just the warmth and letting her naturally, even a pushing direction, giving coached pushing versus natural pushing has an effect on the rate of tear. So there's different types of tears. There's a first degree tear, which is more superficial injury, typically doesn't need to be stitched, depends on if a blood vessel is nicked in the process and there's some profuse bleeding that doesn't resolve with normal coagulation. It's the least amount. It tends to just burn and be sore for a few days with urination just because it's the nerve endings being exposed, so that mild stinging, and then usually in a couple days once those nerve endings heal up. Typically doesn't need stitches and pretty common to see after a delivery and heals pretty quickly. Second degree is a little more common with first-time mothers. It's where it goes more into that muscle tissue. There's direct variations of second degrees. It could be down the perineum, it could be the sidewall, it could be a sulcal tear. It has to do with the location of where that second degree is. So it goes and involves muscles in the perineum, and it may or may not extend into the vaginal wall. It doesn't affect the anal sphincter at all. You may be able to see the anal sphincter, but as long as the anal sphincter is not torn partially or completely, it's a second degree. So there's wide variations of the second degree. It could be the perineum muscles are torn. It could be the sidewall. There's a lot of variations of a second degree tear. Third-degree tears are less rare for midwives and out-of-hospital births, but they can occur. It's where a tear goes into the partial sphincter. There are some privileges where nurse midwives can get training and skills for third-degree repair, but routinely it's not part of the scope of a midwife and would be either in the hospital setting referred to a colleague to finish the repair, or it would be a transfer after delivery to get the third-degree tear repaired. You definitely have more complications, anything involving the anal sphincter with incontinence, painful intercourse, a lot more scar tissue, a lot more healing process to take place. So if they have these issues, they should talk to their midwife, have good communication of what is normal, what's not normal. A lot of times with third-degree tears will have a physical therapist follow up with them to help with breaking up the scar tissue, helping with the pelvic tone, helping to really get that pelvic muscle tone back to normal the best as possible. Fourth degrees are the worst. It's where the tear goes completely through the rectal mucosa. The anal sphincter is completely torn. The women that have that happen, they have extensive follow-up and a lot of complications with pelvic issues, rectal incontinence. Because the pelvic muscles have just been torn, they'll be on extensive stool softeners, they'll be in significant pain for a while. You really want a good practitioner to make sure they're repairing everything appropriately, getting all the rectal linings back together, the muscles back together. It's typically done in an operating room where they need specialized equipment, lighting. Some women need some surgeries afterwards. Like if third and fourth degree tears are definitely something you want to be a lot more careful with management and follow-up support. Preventative measures for perineal tears. Some of the risk factors for perineal tears are outside your control. You can't control how big the baby is, genetics, things like that. Yes, you can help with diabetes. If they need to be induced for a medical condition, is the baby 38 weeks along versus 42 weeks along? There's some things you can control, like we don't do fundal pressure. We really want to be careful with the coach pushing methods, the perineal massage during labor. The birthing position has a huge impact on risk factors, and giving just a gentle opening, the warmth, warm compresses. The water is a huge advocate for decreasing perineal tears. So there's a lot of studies out there finding the most common risk factors for third and fourth degree tears. It had to do with the gestational age and the interventions done during labor and delivery. So instrumental deliveries with vacuums and with forceps, manipulation, aggressive pushing, episiotomies, those things have, laying on their back in the lithotomy position, those things have significant links with more severe tears. You can't control the baby being posterior when it comes out. You can't control a hand presentation. Some of these things we just adapt the best we can as midwives, and that's why we get our suturing training and skills to help with those situations when there is a tear. But I would say, like in the out-of-hospital setting, when there's water bursts and there's instinctual pushing and there's minimal manipulation by the provider's hand, the tear rate is significantly less in a midwife-led birth experience and an out-of-hospital birth experience compared to the traditional hospital management style. And when it comes to pushing, you want to let the mother listen to her body. It's much harder when she has an epidural and she can't feel when she has contractions, she can't feel the baby coming out. But when you allow a mother to birth her child in a more calming, dim lit, relaxed environment, they can go more internal. They can listen to their body versus they're more external. They're going to be able to listen when it starts burning. They're going to slow down. They're going to breathe through it. They're going to push a little bit in between contractions. Like that guided pushing tends to have more complications versus just letting the mother birth her baby how she desires. Keeping the perineum warm, water births are great. We would have with all of our births a real hot bowl of water with warm compresses that we would rotate through to just hold on the base of the perineum. Some women like it, some women don't. It's all about just guided suggestions and support. Some women don't want to be touched at all during the birth experience, and some like to have a little bit of guidance and direction. So that's part of building a relationship with the families that you're serving, but that warmth increases the blood flow. It really helps to improve that warmth and kind of combat that burning sensation from the ring of fire with a mild warmth burning from just the warm compress. Perineal massage, there's mixed studies if it should be done or not done, and it makes a difference if it's perineal massage by the partner at home before the labor starts to help with the stretching and tone. There's mixed studies to show if that helps or not, decreasing the risk of tears. And then there's also the perineal massage during the labor itself and when the baby is coming out. So there's always a balancing act of the more we touch and manipulate tissue, it instinctually tightens up, and the mother will tend to go away from that touch that's outside of her control. Some women like a little bit of guided pressure and a little manual massage, but many women I found, particularly in the out of hospital setting, just holding a warm compress, maybe doing one finger to give just some base guidance of direction if they're a first-time mom and they don't know where to focus their energy for pushing. But as far as manipulating, I've seen some really nasty tears from just the edema and that constant swelling and manipulating of that tissue versus just not touching and letting things be. Delivering in an upright position versus flat on their back, there's a lot of studies that show just equal amounts of pressure on the perineum. There's risk with laying on your back and the vasodilation where you just get lightheaded, and then the non-reassuring heart tones because you're impairing the blood flow to the vena cava from the pressure of the baby on the mom's back. So it's encouraged to always have a tilt and to be to one side or the other, and just support the mother where she wants to deliver her baby, but just being conscientious of if she's going to be more flat, gravity is going to put more pressure on the base of the perineum versus more upright. You're going to have equal amounts of stretching on that perineum tissue with those upright positions. Laying on their side, there's a lot of women that love to lay on their side to birth their babies, especially when they have faster labors, because if you're more upright and you have a history of fast labors, it just intensifies things. So after women have had quite a few babies, I would say it's more common to do side lying deliveries just to help, and just being conscientious that she's not staying on one side for too long, putting too much pressure, helping the baby with rotation in those cardinal movements of labor. It's a lot harder to have episiotomies when they're upright and on their side because the provider's just not down there. It's harder to access, and it's interesting how when we have them in stirrups and the bed's broken down and there's an epidural and they're comfortable and the doctor's been pushing for a while and they're ready to go, there's some biases at play that occur with some of the tears and the episiotomy rates. So you want to be able to do more upright, hands and knees, birth stools, side lying. These all help to reduce episiotomy rates and tear rates. Water births are really popular in out-of-hospital settings. Just that natural warmth, taking away the gravity, being able to have their partner around them, having the room dark, having it more instinctual. A lot of women will deliver their own babies, and it's really an important aspect for reducing the risk of tears to have water births as an option for families. Hands-off technique, which tends to be my favorite, where you sit and you support the mother and you help her in whatever position she wants to get into. You check the heartbeat, make sure baby's doing okay, and you just let her birth at her own pace, and you just give her guidance of support that she can do this and reassurance versus you're counting and having her hold her breath and telling her how to push her baby out. So there's a lot of great evidence to support hands-off approach on the perineum during the crowning process, and this works great during water births because it's just difficult to reach in that position anyways. How to care for a tear if it does happen. There's a lot of variations of it doing the suturing. You can use Vicryl, you can use Chromic, you can use different types of suturing needles depending on the location. But I think the more focus I want is just management those next few weeks after the stitches will dissolve on their own. The midwife has to just make sure there's no significant tear to the anal sphincter, that it's not a deep tear. We're not missing when we're repairing any gaps, that they're going to have some issues with any issues and problems that direction. If you have discomforts, ice is great. We've had a lot of benefits with seaweed, and you can either get in gel or a leaf and get it wet because it promotes the healing. There's a lot of great alternatives out there. I mean, around the world, they use in Japan perineum clips because the midwives can't do suturing. So depending on how complicated it is, if it's a mother and it's a 2nd degree and she had her first baby, she can sit a lot, it might make sense to just have her keep her bottom together a little bit more and watch closely the healing process. Or if she's a busy mom and has lots of flights of stairs and will be pretty active, it might make more sense to give her some stitches on that 2nd degree tear. But the biggest thing is just the first probably 5 days to a week, she's going to be more sore and uncomfortable. The healing process, day 3 to 4, with the inflammatory response tends to be a little more uncomfortable. Our responsibility is to make sure, is this normal healing pain, or is she having an underlying infection? Is there a hematoma we missed? Is there something else going on that needs to be further evaluated versus this is normal tear pain that she's going through? Peri bottles are great, patting and drying, being careful of being constipated so they're not straining and pulling out stitches, particularly 3rd and 4th degree tears. You want to be really careful of softer stools and being proactive with lots of water, activity, fiber, stool softeners. So just as a summary conclusion, there's a lot of different tears that can happen. There's a lot of great ways as midwives and out of hospital, and even in the hospital setting with physicians and support, and how we as practitioners approach the birth process significantly impacts how many tears are going to be present for the families we serve and how significant they're going to be. So there's a lot of preventative measures we can do. There's a lot of things we can support with stitches and the recovery process to help them to restore their pelvic tone, because it's not just a vagina is not just an organ for birthing a baby. A lot of women have and they want a strong sexual being after they have their babies. So it's our importance and our duty to be able to give collaborative support for the mother during the birthing process, during if the stitches are present, an appropriate repair, and then a follow-up collaborative support for the healing process with local pelvic floor therapists, exercises that are available, and if it's significant tears and not healed, well, reconstructive surgery. So we just want to be able to be that gateway so that women can have a lower risk of tear. They can be as healthy as possible after the baby comes, and lifelong they're not going to have pelvic pain and complications from their birth process.